Thank you, Dr. Roto, for the whirlwind tour through EGFR. And I'll invite all of our panelists to turn their cameras back on, and we'll do a brief panel discussion. I'll target some questions more directed to certain people, but I know all of you treat lung cancer, and so feel free to also unmute yourself and answer after the question is directed to the group. You're all welcome to answer as questions arise. I'll start with Dr. Cooper, just because you were first. Are you still utilizing chemo-free intervals at all in your practice? With all of these new agents, with tarlatamab and sequencing, how does that play a role, or does it at all anymore?
Yeah, that's such a good question. And I think one that's actually still quite controversial and up for debate. I think if you asked a bunch of different oncologists, you might get many different answers. To frame the question, when deciding how to treat patients with small cell lung cancer that had grown after their first sort of induction chemotherapy, we used to sort of conceive of this chemotherapy-free interval, meaning the amount of time that patients were on immunotherapy maintenance. So the amount of time that had passed since they last seen platinum-based chemotherapy for their small cell lung cancer. And we thought of those in different chunks. 3 month was sort of one interval, 6 month is another interval. And how we used to think about that is that patients who were further away from that chemotherapy, typically 3 to 6 months, and certainly more than 6 months away from chemotherapy, we consider that cancer growth to be chemotherapy sensitive, and could actually, part of the paradigm would be to retreat with the original chemotherapy that the patient had already received, because the thought process was that that cancer that was growing kind of didn't recall or remember its exposure to that prior chemotherapy. Now, the NCCN guidelines, the guidelines that all oncologists follow for the standards of how to treat patients with all cancers, are actually moving away from that chemotherapy interval framework, which is really revolutionary, I think, for the field. Personally, I think that everyone deserves a shot at a novel immunotherapy like tarlatamab or clinical trials. I'd like to emphasize that for small cell lung cancer in particular, the NCCN guidelines really highlight that actually clinical trials are probably the best choice for most patients if they're eligible and able to undergo clinical trial, just because we really are pushing the forefront with novel therapies here. But in general, I'm not actually thinking about that chemotherapy-free interval too much anymore. I will say that sometimes patients may be in a situation where it's been a long time since they've received chemotherapy. Maybe they might have even had limited stage disease that has now recurred, years later. And they might have really high volume disease that needs to be treated very quickly. I might consider that chemotherapy might actually be a better choice for that patient at that point in time than a novel immunotherapy, when we really want like a quick response to kind of get that patient, that disease under control more quickly. So it's not to say that chemotherapy doesn't have a place in treating small cell lung cancer, and that's certainly not the message I want to convey. I think now we just need to be a little more thoughtful about each patient and their treatment history.